I'm Dr. Snigdha Chitnis, and I'm the category manager here at Medvarsity. I'm back in conversation with Dr. Sai Praveen Haranath, and let us today talk about cardiology and the cardiac part of the critical care. I think, a scenario of an elderly person clutching his chest was something that we, used to deal with in earlier times. But I think given the stress, we are looking at a lot of middle-aged people who are suffering from cardiac episodes and collapsing. So is there a different protocol in 2021 than it was before?
Sure. So I think one of the things to realize, Dr. Chitnis, as you said very rightly, is that cardiac complications of modern life are widespread, and we've heard of even 30-year-olds getting heart attacks. We've heard of 40-year-olds, etc. And luckily, technology, science, medicine has evolved quite a bit, but clearly stress has gone up with that, and we've heard of so many people collapse the workspace, for example. And one of the things to realize there is that emergent care is critical, because more than 180 seconds of the brain not getting blood, if someone's heart stops, they're done for, right? You don't have a good cardiac and neurological outcome. So you have to immediately, when somebody collapses, obviously check for a pulse, and then if you have access to, which we hope many places have, is look for an automated external defibrillator, an AED, and look for ventricular fibrillation, which is actually a very common cause of people collapsing and of people with heart attacks having ventricular fibrillation. Once you have done that, you've connected it, and the machine analyzes and either gives a shock or not, you can either a lot of times save lives. You have to also consider the basics of cardiopulmonary resuscitation, which is CPR or chest compressions, and you really should have everybody trained in this. And this video aside, everyone should know how to do CPR. Everybody should have access to an AED, and these are things which people should be thinking about, because these have been clearly shown to save so many lives in many economies. We do have many AEDs, but they're not widespread enough. Once somebody has a heart attack and you've stabilized them, you got their rhythm back, and you've taken them to the emergency room, you may often need a cardiac catheterization done very early, and you can often find a blockage in one of the arteries, and the catheterization procedures are so advanced now that they can very often fix it permanently, put a stent or dilate it. So many other new techniques are out there. Of course, there are some people who might need urgent heart bypass surgery, and you can always recognize this with the help of a cardiology and a cardiothoracic team. So once they end up getting their procedure, they end up in the ICU, and I think we were chatting earlier about what happens to these patients, and a lot of times they end up need to be monitored, because after heart surgery or heart attacks or a heart procedure, they may get irregular heart rhythms, their blood pressure may fluctuate, and the heart pumping function might vary a bit, and they will often be on very powerful medicines like blood thinners, and they'll be at a risk of bleeding, and you have to be cautious about watching these carefully. Many of them also have large catheters which are removed, and you have to make sure they don't bleed from there. So a lot of times they need intensive care for some amount of time, and then once they get out of the ICU, you kind of monitor them. And long term, many of these patients require close follow-up to make sure that the heart pumping functions better, that their rhythms are regular, and many of them end up with many medicines like cutting the cholesterol down, antiplatelets, blood pressure control medicines, and if they've had complications, for example, somebody with a heart attack might end up with a third-degree heart block, and they might need a pacemaker, which may be temporary, then end up being permanent. So if you look at a simple case of somebody with a heart attack, it may need long-term follow-up, and they might even need things like rehabilitation, like cardiac rehab, where they actually have to kind of get back into graded exercise. And exercise is good for the heart, but once you had a heart attack, you want to get your doctor's advice about how to kind of increase what's called the MET. The MET is the metabolic equivalent, and you want to see how much exercise do you do at what pace, so that you're not kind of injuring the heart more. So a cardiologist can obviously give better advice on these areas, but the critical care aspect of this is mainly about monitoring patients right after a myocardial infarction, and trying to kind of trend the enzymes, looking for complications, and also kind of advising the role of medicines to control rate, for example.
Okay. Should we talk a little about, since you were talking about enzymes, can we talk a little about the role of C-reactive protein and how you can monitor it to then get the patient out of the range?
Sure. See, the CRP is probably honestly best used in an outpatient setting, where there have been studies showing that HSCRP or highly sensitive CRP correlates with cardiac disease, and treatment might actually improve the numbers, and inflammation triggers the CRP to go up. In acute settings, the CRP is a very non-specific number, so you may actually want to think about using highly sensitive troponin. So troponin levels can actually go up with myocardial infarction, with heart damage, but a lot of times troponin elevation doesn't always mean that there's a heart attack. It might just mean that there's strain on the heart or a stretching of the heart muscles, for example. But a troponin is a very good indicator that's cardiac myocardial damage, muscle damage going on.
It's more specific than CRP given
Correct.
because it actually looks at the myocardial damage.
Exactly,
Yes.
correct, right.
Okay. I would like to know, since you have been working in the ICU for I guess 2 decades, sir?
Something like that, right? Yeah.
So, is there a certain protocol that you follow when a patient with cardiac pain enters into your ICU?
Sure. See, fortunately for us, most patients don't end up in the ICU with heart pain because they're generally already treated. Because you generally show up either from home or in the hospital, you end up in the cath lab, they treat it. But when they end up in the ICU, you have to kind of evaluate them for several factors of stability. It may be the vital signs, like cardiac vital signs, heart rate, blood pressure, is it okay? Sometimes if you have a heart attack, you might end up with congestive heart failure, and then your oxygen level might be low, and you have to make a decision: do they need the ventilator? Do they need a non-invasive ventilator? Do they need PEEP on the ventilator, or the non-invasive ventilator, or the EPAP we call it? Do we need to adjust that? You also have to give them diuretics to remove fluid and decongest their lungs sometimes, and that can cause electrolyte imbalances. A lot of times people with heart attacks might have kidney damage because for whatever duration the heart wasn't pumping, the kidney, which is very sensitive, might end up with acute kidney injury. Then you have to monitor and manage that. So the number of things you have to look at with even a patient with a heart attack is kind of global, in the sense that you have to look at all of these different factors. And fortunately, critical care has evolved enough that most doctors kind of can handle this. But there are situations where we do remote intensive care. We're actually looking at patients who are far away who had a heart attack, and then we have to help them triage giving a thrombolytic drug because they don't have access immediately to a cardiac cath lab, and we may have to plan on them shifting when they're stable to getting a cardiac cath down the line.